My case is actually not a very complex case, but I thought we'll present because we had some nice looking images and you know how imaging can help in a situation where you don't know what to do. So this is a 80-year-old gentleman who's a non-hypertensive, non-diabetic. He had an angioplasty to ramus in 2015. This was done outside. So he presented to us with exertional angina, which is becoming more for the last 3 months. On examination, ECG was normal, echo showed normal LV function. And in view of this past history of angioplasty and now exertional angina, which was increasing, we thought we'll do an angiogram, and this was planned in August 2020. So this is the angiogram, and you can see that the LED looks okay, some mild disease in the mid segment, and as we go forward, we'll see some ostial LED plaquing, distal left main plaquing. The ramus is flowing well with the stent. Circumflex is non-dominant with some ostial disease at the circumflex ostium. But now in this view, you see that there is some hazy shadow in the LED ostium. It's not much, but it's definitely there. So, you know, these lesions didn't portend, that the patient is having angina. Very difficult to find out where he's having the angina from when you see these kind of lesions, especially if you look at the RC, also some mild moderate disease. So the only point of interest here was the LED ostium area, and we thought that this definitely needs an imaging. And this is the imaging run. You can see that some moderate disease in the mid LED, and as we go forward, we are coming to the LED ostium area, and there is, lies the money, where we see very clearly that the ramus stent is now, it's gone right into it's quite deep inside the LED distal left main, and this is probably what is pinching the LED ostium, and you see this double barrel kind of an ostia there. So these are the still images analysis. We see that very clearly here, the LED ostium being pinched by the ramus stent, which is the struts are getting endothelialized, and we have a very nice 3D bifurcation view. When we move around, we see that you can see it as a complete circle inside the LED lumen, and the stents also, you can see the tissue overgrowth over the stent struts. So that VOCT is very nice in showing these beautiful images, probably better than IVUS. And we see the LED ostia in the cartoon number C, and you see it's almost like a slit-like LED ostium. So the plan was to actually do a DK crush sort of a situation. We took the ramus stent as a side branch stent which has already been deployed, and we thought we'll do a LM to LED and crush this stent and try and get a good result. So the distal diameter was 4.2. This is media to media. Proximal in the left main 3.5, but this was lumen. So we thought a 4 millimeter stent would be right in this kind of a situation. And the length was about 34 millimeters. So going forward, the LED was pre-dilated with a 3 millimeter balloon, and we crushed the ramus stent again. I think it was a 3.5 millimeter balloon, so that we could get adequate crushing of this ramus stent, which was extremely important. And then optimized by putting in a balloon into the ramus so that we get this side branch optimization, and then did the first kissing. This is a 2.5 millimeter balloon in the ramus and a 3.5 millimeter balloon in the LED. So this was the stent deployment. I'm sorry, I'll run it. So this is the stent deployment. You can see when the stent deploys, you can actually see it opening nicely and crushing that stent as well in the ramus. Okay, so this was the first pot which was done. This was with a 4 millimeter balloon, and then this is the second kissing, again with a 4 and 2.5 millimeter balloon, followed by a repot, this time with a 4.5 millimeter short balloon. This is the LED to left main post PCI run, and we can see that looks fairly okay. no malapposition, good expansion, at least 80% all across. And when we come to the area of the, ramus, where exactly the problem was, we see that it's a fairly decent looking result. And you can see the ramus ostium from the LED run here, and yeah, some struts there, but nothing really dramatic the way it was looking earlier. So this is the still images. We see a good area, 9.9 in the distal LED, 7.8, 7.9 in the mid, and almost 16% in the left main. And this was the 3D bifurcation view showing that the ramus ostium was, very well open. Maybe a strut or two across the circ ostium, but it was a non-dominant circ. But still, we wanted to see whether this circ required any intervention. So this was the final angiogram. Did a FFR to the circ, which was quite normal, 0.94, 0.95. So these were the final images. And the patient did well for a year, and after that he had some chest pain, so we jumped at the opportunity to do a check angio a year later. The stent was widely patent, left main to LED, the circ had not deteriorated, and the ramus was flowing well. So the learnings are that OCT and imaging rather is invaluable and modality of choice in clarifying ambiguous angiographic findings. When we try true ostial nailing of lesions, especially in branch vessels, it is always fraught with some dangers of compromising the lumen and flow in the parent vessels, which are far more important. And if we do such a thing, then it is advisable to image at the time of the initial procedure, so that if there is any problem, you can correct it immediately. All the suboptimal findings can be looked after, so that we can give excellent long-term result to patients. And in this situation, we used left main intervention was done with a DK crush strategy in an innovative manner to give durable result in a previously protruded stent in the proximal LED. Thank you.